Hello and welcome. I'm Tafarra Gadamu. Serena, who a noted orthopedic surgeon, teaches and practices at Stanford University. For a second year in a row, she has joined a team of volunteers treating patients with multiple scoliosis. Why is that a life-changing experience? A very warm welcome to the program, Professor Hu.
Thank you for having me.
So you just came straight from the operation theater, right?
Yes.
This is your case number?
For the whole team?
For you.
For me, 20-something. Yeah.
So you have, in the last 11 days,
Yes.
you operated on 20 individuals, 20 patients at the very least.
My team, not me exclusively. I have two other surgeons with me.
Right, exactly. So you're dealing with scoliosis, right?
Scoliosis, which is a side-to-side curvature, but also kyphosis when you're bent over. And we see that very commonly after TB, for example.
You're treating severe cases of scoliosis. Yes. Is that correct?
Yes.
Can you explain to me how that happens?
Scoliosis is... I don't want to say common, but it's, around the world. We think that it might have a slightly higher prevalence here in Ethiopia, but it's at least 1 in 1,000 in the United States and perhaps as high as 2 or 3% in Ethiopia. And when you treat it early, you can brace it. You can do surgery early. But in Ethiopia, unfortunately, because of some of the access to healthcare or lack of information, sometimes also lack of awareness, I think many of the cases here don't get recognized until fairly late in the game. So we see very severe cases when we come here.
So that makes surgery a bit too complicated, right?
Oh, it becomes much more complicated, yes. Much more risky, too.
So can you tell me more about that in relation to what you have handled the last 11 days that you've been here?
Yes, so we've done some very severe cases and some that haven't been quite as severe, partly because if you get a moderate case, but you know it's going to progress, it's better if you have time to take care of that so it doesn't become a severe case, right? But then there's many patients that have such severe cases that they're in much pain. They can become disabled because of the pain. They can't walk correctly, for example. And those are the kind of cases that we've been prioritizing. But they're riskier cases and they take longer. So we have to balance the complexity of the case and the risk versus taking care of patients before they get to that stage.
When you say longer, what do you mean?
The cases take longer? Yes. So like the case I did this morning was a relatively easier case. It was a 60-degree curve, and that took us 4 hours.
60 degree?
Yeah. And then, but it'll take... there are cases that might be 100 degrees, for example, and they might take 6 or 8 hours, for example. Mm-hmm. So they can definitely take longer because it takes longer to straighten things out. It takes sometimes you take out a vertebra. It's harder to put the screws in, so it becomes much more difficult and complex. Your
partners here who organized this for you do the screening, right? Can you guide me through that process?
The process. So Dr. Rick Coates, who I think you know, is certainly definitely Ethiopia's expert on spines and probably of all of East Africa as well. And he's very well known for spines, and so people will find him in his clinic, in his office, if they have a spine problem. And he also does outreach and will go to the countryside and screen for patients that might have scoliosis or kyphosis. And if they're a possible candidate, then there are a number of tests. And if the patients are interested, there are a number of tests that get done to see about their fitness, their health, those kind of things. And then some patients will get sent to India or Ghana if they're very urgent or very, very, very high risk. But that's obviously much more difficult for the patient and more expensive. And if the patients are appropriate for being done here, then he will send the cases to Dr. Ted Bellinger, who started this about 8 or 9 years ago. He's been coming for many years. Last year I joined Ted for a week, and then this year I joined Ted for a week and then stayed an extra week. And so Ted will select the cases based on some cases that are very severe that need to be done before they get worse, or perhaps sometimes moderate cases that we know are going to get worse because we don't want to get them to get so severe that they become too complicated or too high risk. And then balancing, because you can't do all complicated cases all the time because it's very, very stressful on both physically and mentally. And so you have to have a balance of kind of the harder cases and the more moderate cases. And so trying to prioritize what's the need and the kind of predictability. So Ted selects the patients for that. And then this year I came in and helped out and stayed on. So
these are in large measure patients who do not have the resources, right?
That is correct. I mean, it is charity work. So JDC pays for the surgery, but relies on donations to be able to provide for that.
So these patients are anywhere between 12 and 35, is that correct?
That's probably the average, but we've seen patients in clinic as young as 10 or 8. Sometimes the really severe cases like that need to be put in traction for a while, and right now we don't yet have that capability in Addis, but it's possible with the Cure Hospital. They will be starting to do more spine and may be able to help us with that. So the younger patients we tend not to see as often.
So how do they react when you undertake this operation?
The patients are the reason we're here is because, just to be able to change somebody's life so much and see the first day they're in pain, don't get me wrong, but in a few days they're walking down the hallways, they're taller, they're straighter, they feel better, and the look on their faces and the just life-changing nature of what we can do for these patients is really why we come here, because it is such a impactful thing that we can do, and to be able to do it when they wouldn't otherwise have access is really very, very special. We feel very privileged.
Normally, this is a very expensive intervention, right?
Yes.
Can you explain to me in relation to how you go about it in the U.S.? You said, for example, the serious cases of sclerosis in the United States, you happen to handle 1 or 2 or probably 3 max, right? Serious cases?
Yeah, I mean, we definitely see more severe cases here. Financially, because in the U.S., most patients have some kind of insurance and they have access. And if you don't have insurance, you get the state insurance. And so you can get treatment earlier and usually for when it becomes less severe. Here, the costs are less here, obviously, because the cost of living, everything, the hospital cost is less and things like that. We use implants. We have to use screws to kind of hold the spine straight with rods and screws. And those are largely donated by companies because they're very, very expensive. If you have...
If you were to pay for them, you'd be very expensive.
Yeah, and that's actually how they do... I believe that's how they do it here, is they give them a prescription with what screws they need and they have to get them. And so that's actually limited how many patients can afford them on their own. So I think that's very important to keep in mind. And then the surgeons, we donate our time. We have technicians, both scrub technicians and neuromonitoring technicians and even an anesthesiologist, and they donate their time. So the hospital does obviously take money to run. So their people, cost money, and for their staff, for use of their operating rooms. They actually are very, very good to us at the Korean hospital. They actually give us room to work, and that means their doctors aren't working, and they give us access to they let us work on the weekends so that we can do more cases. And so, we rely on a lot of goodwill and a lot of charity and volunteer work to make this all happen.
And you have, you mentioned a few, right? You have this Ethiopian orthopedic surgeons who join in the operation, right?
Yes. There are 3.
Tell me about that experience, that connection with us.
That is very, very essential for the program working. A number of reasons. Number one is they're spine surgeons already, so they have experience. Number 2, they're wanting, obviously the goal, the expression, of course, is you teach a person to fish rather than giving them a fish. And the more that they spend time with us learning what we do and learn to do it on their own, the more likely it is that, not that I wouldn't want to stop coming here, but that they don't need us to wait for us to come do the cases. So they can do cases on their own. And they've started doing that. There's been one doctor Dr. Abraham, who's been doing this for probably 4 or 5 years, and the other one for 3 or 4 years. And then another doctor Dr. Iskinder, who just spent a year in India training with some Indian doctors to do this kind of surgery. And so again, you need to have people here to do the surgery. So they work with us, number 1, to assist, so they learn to get better. Number 2, they follow the patients afterwards because there's always possible complications. And they're also very helpful because they help with translation, because obviously my language is not very good.
Teaching people how to fish, that's very important.
Yes.
But 10 days, 11 days here in Ethiopia, do you think that's enough?
No, not immediately. But if you come year after year after year, and every year the doctors learn more, and they've started doing some of the more straightforward cases on their own. So I think, and these are spine surgeons to begin with. So it's not like you're teaching them, you're teaching them the fish, but they already know how to catch some fish. They just don't know how to catch a certain type of fish, for example. So it's more, the complexity is not something that they feel comfortable doing on their own just yet.
Because the need is so massive, right?
Yes, it's very massive, yeah.
And it's just like a drop in the ocean.
Oh, it truly is a drop in the ocean. I think Rick Codes the other day estimated that he sees 500 new spine patients a year in his office, and then when he does outreach, it's probably another 500 patients. And if we did, 50 total, that's a tenth per year, and he's getting more and more. So between the volunteer work that we do, but the Cure Hospital they've started doing some spine surgery, and Rick Codes' group has approval to start a spine center with spine surgery. I can't remember which hospital it is, but they've...
Here in Ethiopia, in Addis.
Here in Addis, yes. And they'll be hiring for that. So it's still a massive number of patients, but you have to start someplace.
So you're doing this operation here in Addis Ababa, and specifically that hospital you mentioned, the Korean hospital, right?
Mm-hmm, yes.
No plans to do these operations outside of Addis Ababa, because there are other universities, teaching hospitals.
I don't have an immediate plans. I mean, I think with the two other places, with Cure Hospital starting to do work, and the other hospital that will start also, it might make sense for us to help there and help teach there. But right now, everything seems to, again, they've been very welcoming at the Korean hospital, so we'd be happy to collaborate. I've talked to the head at the Cure Hospital, and we plan to collaborate. I don't know if there will be a need for me to actually go over there to operate, but certainly to work with them to try to reach more patients and help more patients.
You work and you teach at one of the few top universities in the United States, Stanford University. It's interesting that you're spending so much time here in Ethiopia, providing your service gratis, right? Mm-hmm. What does that say?
It is, as I mentioned, it just being able to help people that wouldn't ordinarily get the care, just looking at the look in their faces, and just they always, there's a common saying that when you go do volunteer work, we give, but we get as much in return. The gratitude, the feeling that you can help a greater good. I mean, I have very grateful patients in the United States. I have very great colleagues, but it's a different mindset here. It's a different sort of gratitude. If I didn't do the surgery in the United States, somebody else would do it. Here, if I don't do it, nobody does it. So, and then the patients can continue to get worse. So it's a different level of kind of, I don't want to call it importance, but impact is probably a better term.
Do you get in touch with patients that you have operated on? For example, last year, the first time was last year, right?
Right.
You meet people from last year. What did they tell you?
Yeah, it is really fun to see them. So Dr. Ted did the Bellinger. He did the clinic, post-op clinic, the other day while I was doing surgery. But we have many pictures of him, and the patients are just very, very happy and very grateful. And even some of them that had some mild complications have recovered nicely and seem to be doing really well. So
you plans to come back again next year?
Yeah, I do plan to come back next year. So we're going to work on timing. Probably this next year will probably be the similar time, May, June.
May, June.
Yeah.
You'll be coming alone, or you'll be spreading the word? How does it go?
Actually, it's interesting. So I'd like to spread the word, but the people that we brought this time were so amazed and impressed by the patients and just the experience that I think they want to come back. And so I don't know if we'd have another team, on top of that or whatever. So if the same people come back, they already know what it's like. It's good to use the same people because we already have the rhythm. We already understand each other, and you can work. It's good to have a team that's used to working together.
Professor Hu, Thank you very much indeed. It was a pleasure having you on my show.
Thank you so much. It's an honor to be here and be speaking with you.